Recording in progress.
It's 7 p.m., sir. We'll start.
Sure.
A very good evening to one and all. I heartily welcome all the members of API, ICP Karnataka, and other members of various organizations who have joined virtually from all over the country to attend this program of World Asthma Day. On this occasion, I welcome Dr. P.S. Shankar, Professor Emeritus RGHS and KBN University, Gulbarga, Dr. Muruganathan, past Governor, ACP India Chapter, past Dean ICP, past President API, currently the Director of PRF. I also welcome our own committee members, our patron API, Dr. Maya, Dr. Murali Mohan, Chairman API Karnataka, Dr. Vishwanath Secretary, Dr. Ravi Kirti, and Dr. Srinivas Murthy, Central API members. I welcome our today's chief guest, a dynamic president, elect National API from Kolkata, a great academician, researcher, received many awards, served in many capacities in various organizations, putting National API in global map with many countries involved with API and doing many dedicated programs to teach postgraduates and junior doctors across the country. Dr. Jyotirmay Pal will be joining shortly. I also invite our today's speaker, Professor Dr. G.C. Khilnani, Chairman and Chief Pulmonologist and Critical Care Physician, PSRI Institute and past HOD, All India Institute of Medical Science, Delhi. A senior faculty, dedicated teacher and academician with many publications, received many awards, loves to give talk and educate in many platforms to students and general public in mass as well, associated with NAMS teaching as well. I also welcome our today's chief moderator, Dr. Ravindra Mehta, chief pulmonologist and a dynamic interventional pulmonologist from Bangalore, who has passion in mastering techniques in interventions and working in best of pulmonary centers with all advanced facilities and rehabilitation as well, with many publications to his credit. I also welcome our panelist, Dr. Nagarjuna Mattur, chief pulmonologist from Yashoda Hospital, High Tech City, Hyderabad, a alumni of PGI with lot of new works being done and has many publications as well to his credit. I also welcome our other panelist, our own faculty, Dr. K. Satish, a senior pulmonologist from Manipal Hospital, Bangalore, dedicated to academics and a lot of research work being done and published. He received many awards. Let us not waste time by reading their CV profile, which runs in pages. Let us learn and hear from them. As I can see, many have joined virtually from many states of the country, making a national event, which COVID-19 pandemic has taught a new normal life to learn. Lastly, I welcome one and all. Now we have a formal virtual inauguration.
शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तुते शुभं कुरु.
We are virtually honoring all our faculty members as well.
ಈಗ ನಾನು ಭಾಷಣ ಮಾಡ್ತೇನೆ. ಏನು ಹೊಸದೇನು ಇಲ್ಲ.
Yeah, now I request Dr. P.S. Shankar sir to address and for your introductory remarks. Over to you, Dr. P.S. Shankar.
Thank you. Dr. Jyotirmay Pal, Dr. Muruganathan, Dr. Khilnani, Dr. Mehta, Dr. Nagarjun, Dr. Satish, Dr. Maya, Dr. Murli Mohan, Vishwanath, Sangram, Ravi Kirti, and LSM and colleagues. We have assembled here today in connection with the WAD. I am happy my friend Khilnani is the speaker, and I welcome him and Dr. Jyotirmay Paul, chief guest, and all other distinguished members of the API and ICP. World Asthma Day is an annual event organized by the Global Initiative for Asthma, GINA, a collaborative organization of the World Health Organization established in 1993 to improve the asthma awareness and care around the world. The World Asthma Day is held since 1998 on the first Tuesday in each May to raise awareness of asthma worldwide. Dina has selected the theme Asthma Education Empowers to emphasize the need to empower people with asthma with the appropriate education to manage the disease and to recognize when to seek medical help. Healthcare professionals are called upon to increase their awareness of the continuing avoidable morbidity and mortality from asthma and the published evidence on the effective management of asthma so they are equipped to provide reliable information and optimal treatment for their patients. Asthma is one of the most common chronic non-communicable diseases that affects over 260 million people and is responsible for over 450,000 deaths each year worldwide, most of which are preventable. Bronchial asthma is a complex and heterogeneous syndrome characterized by episodes of intrathoracic airway obstruction, airway hyperresponsiveness, and airway inflammation, resulting in episodic occurrence of dyspnea and wheezing, which varies widely over time, either spontaneously or in response to treatment. Multifactorial stimuli are responsible for airway hyperreactivity leading to obstruction. Asthma includes a heterogeneous group of patients, and attempts are made to find out a common denominator among the situations such as chronic inflammation of the airways, allergy, and psychogenic factors. But the unique common denominator has been shown to be hyperreactive airways, which manifest with variable airways obstruction in response to a wide variety of endogenous and exogenous stimuli. Heterogeneity of asthma includes precipitating factors responsible for an attack of asthma, such as extrinsic, intrinsic, or mixed. The airways obstruction may be located in the small airways, large airways, or both. The degree of reversibility of the airways obstruction may be complete with short or long duration or incomplete. The onset of the attack may be sudden or insidious. The severity of the attack may be graded as mild and infrequent, frequent and episodic, or chronic with mild, moderate, or marked severity. The periodicity of attacks may be seasonal and perennial. The attacks may occur as nocturnal asthma, morning dipping, or labile asthma. The duration of the attack may be short or long. The symptoms are characterized by breathlessness, cough, or both. The attack may be respond to bronchodilators, anti-inflammatory agents, or both. The clinical categories of asthma include extrinsic asthma, intrinsic asthma, occupational asthma, childhood asthma, exercise-induced asthma, drug-induced asthma, reflux-triggered asthma, nocturnal asthma, allergic bronchopulmonary aspergillosis, on which we are discussing today, carcinoid syndrome, allergic angiitis, and granulomatosis. Key universal issues on which education is required are under or inaccurate diagnosis, underuse of the anti-inflammatory inhaled corticosteroid inhalers, overuse and over-reliance on short-acting beta-agonist SABA inhalers, and poor recognition of the patients requiring specialist assessment and further management. The first World Asthma Day in 1998 was celebrated in more than 35 countries in conjunction with the first World Asthma meeting held in Barcelona, Spain. Participation has increased with each World Asthma Day held since then, and the day has become one of the world's most important asthma awareness and education events. This theme emphasizes the need of educating people with asthma on how to manage their disease and when to seek medical attention. There is an address on allergic bronchopulmonary aspergillosis today. ABPA is often considered as a complicated or special variety of asthma wherein immunological reactions to aspergillus species play an important pathogenic role. The allergic manifestations depend on the intensity of the exposure to the aspergillus and immune status of the host. In the background of the bronchial asthma, there are symptoms and signs of worsening airflow obstruction. Aspergilli can colonize in the medium-sized bronchi, where their growth results in an increased amount of the antigen locally and brings hypersensitivity reaction mediated through the reagenic and the precipitin antibodies. There is no tissue invasion, and the condition is noted in atopic asthmatic individuals. We are eager to hear the presentations on ABPA and the panel discussion. I wish the program all success. Thank you. Thank you very much.
Thank you, sir. Thank you for an overview of introductory remarks over the bronchial asthma. Now I request Dr. Muruganathan sir to say a few words.
Good evening, dear brothers and sisters. You heard Dr. Professor Sankar was giving the overview of asthma. So I don't have anything else to add, but of course, I'm eagerly waiting to listen to Dr. Kilani on aspergillosis. Only thing what Sankar has not said was the newer drugs in asthma, which are now the monoclonal antibodies. Now, you know, they also, apart from the inhalers, they also use monoclonal antibodies in various types of asthma. And one more caution, always, you know, you must you have a clear knowledge about asthma, because sometimes the COPD may mimic like asthma, and then COPD leading to carpal which is a cardiac asthma, also can mimic like asthma. So you'll have to be very careful when you deal with a patient with breathlessness. With this point, I now have happy to hand over to Sangram, who is doing excellent work every time. I don't know whether Jyotirmay Paul, my brother, has come.
Yeah, joined, sir. Joined.
Oh, he joined, is it? Okay.
Yes, sir, I have joined.
Okay. A word about Jyoti. Jyoti is a dynamic, my younger brother of myself, who is doing extremely good work academically. He loves teaching, and he's always have a group of students who are always with him to do research. So myself and Jyoti are going to take over next year. He's going to take over as the president. I'm going to take over as the research director. We are looking forward to do a lot of research. I request Professor Klani sir to give us some hints on research on aspergillosis and various types of asthma. Over to you, Sangram. I wish you the function all success.
Thank you, sir. Thank you for your kind words of wisdom. Now I request Dr. Murali Mohan sir, Chairman API Karnataka, for a welcome address.
Thank you, Professor Biradar, for inviting me to be part of this. I'm, as always, impressed by your passion for education, and that ties in very neatly with the theme for this year's World Asthma Day, empowerment through education. So that is what we're striving to do every day, educating our patients, of course, educating the general public as to the hazards this may hold, but also educating our fellow professionals, because asthma is handled by everybody, from the general practitioner, very often it's the unqualified person, to a pulmonologist, and so on. So it's a pleasure to be here. A very special welcome to our speaker for the day, Professor Kilnani. We've always heard him from the times when I was a student, and he's always been a fount of knowledge for us. And three very dear friends who are part of the panel: Dr. K. Satish, my MD batchmate, Dr. Ravi Mehta, who's always, you know, a tower of strength in Karnataka's pulmonology, and one of the most innovative persons we've ever known. And of course, a dear young friend, Dr. Nagarjun Maturu, who is one of the persons responsible for putting Hyderabad right at the top of pulmonology in this country, and soon to take it to very high, great heights in the world. ABPA, a very special variety complicating asthma, is something that is being increasingly looked at, increasingly recognized, thanks to more and more availability of CT scans. And we've had several criteria that have been used to make the diagnosis of ABPA. And I'm looking forward to Professor Kilnani discussing these. And of course, a very, very special welcome to our very senior Professor Shankar, Professor Muruganathan, and the API chief, Professor Jyotirmay Paul. He's always been, so interested in research and in education. So, sir, it's wonderful to have you all here. And a very large group of people have logged in. Welcome to all of you. And back to Professor Biradar.
Thank you, sir. Now I request our chief guest of today's function, Dr. Jyotirmay Paul, for your inaugural address.
Thank you for inviting me in such a prestigious program hosted by API Karnataka branch. So, good evening, Chairman API Karnataka branch, Secretary API Chairman branch, Dr. Sangram Bihadar, Dr. Ravi Ketty, my very good friend, Dr. Muruganathan, Dr. KK Parekh, past President, past Dean of API, and all the delegates, my brothers and sisters and students. So, I first congratulate the API Karnataka branch for hosting such a webinar in a particularly special day, that is a World Asthma Day. The asthma awareness is very much important, as told by the author. Is one of the most common chronic problem, but it can be not only controlled, can be cured if we take the appropriate measure in appropriate time. But there is a lot of barrier. That is the importance of celebrating the World Asthma Day, to make the awareness should be increased among the physician and also among the people. The physician, they should know, Dr. Muruganathan, what was discussing about the appropriate differential diagnosis. So we should not overdiagnose, we should not underdiagnose the asthma. So we have to differentiate it from the similar problem, maybe aspergillosis, COPD and others. And at the same time, we physicians should know to use the medicines very correctly, and also to educate the general practitioner correctly, so that we can treat the asthma very appropriately, and also the use of the newer drugs. I don't know whether the common people are attached today, most probably not in the Zoom, but I suggest all the API branch should set up such initiative to educate the common people also, apart from the physicians and practitioners. Because if we give the correct treatment, but if people is not aware, the so
Yeah, Dr. Jyoti. I think the internet instability is there, I think. Dr. Jyotirmay Paul.
I think he's lost his connection, Dr. Biradar, sir.
Yes, sir. Yes, sir. Yeah, Dr. Jyotirmay Paul.
Dr. Biada.
Yeah, there was little internet instability. Connectivity was lost.
Oh, okay. Okay,
Yeah.
sir. So
Yeah.
I congratulate API Karnataka branch. I hope other branch also takes such initiative to educate the physicians, practitioners, and so also for the people. That is my message. Because you are aware, you give the best treatment, but people is not ready to take the best treatment. So awareness among the people also very important. So they should know what is asthma and what is the best treatment, because there is a lot of barrier when you prescribe the inhaler among the people, like the insulin. So this barrier also to be broken. So awareness of the people, I hope not only in asthma, many other diseases also, the barrier, the inhibition of the people, that should be broken. And such API in future, at least I think in my presidency I will advocate this apart from the awareness of the physicians, awareness of the people, that is to also be generated, and API have to take a leading role to fulfill this gap. Thank you, Dr. Bihadar. Thank you. I wish all success.
Yeah, thank you, sir, for sparing your valuable time. Now we move on to the scientific session. I request Dr. Ravi Mehta, I think he will be joining shortly. Request Dr. Professor Khillani to present your talk on the subject allotted. Over to you, Dr. Khillani, sir.
I'll share my slides, sir. All right. So, good evening, senior physicians, ladies and gentlemen. At the outset, it's my pleasant duty to thank Dr. Sangram Biradar for bringing me amongst you, and I'm really grateful to ICP and API Karnataka branch for promoting this academic activity. And especially, I should be grateful for me to get in touch with Professor Shankar, who is like my teacher, and also giving me an opportunity to discuss what is very close to me. And I've been actually talking about it. And the time allotted to me, if I am able to create an awareness among the physicians who are connected with this, my job will be done. So, as emphasized, the burden of asthma is tremendous. This particular global asthma network came out that 9.1% of the children all over the world are having asthma, 11% of adolescents, and 6.6% of adults have asthma, and as many as 262 million, some studies say 350 million people all over the world have asthma. And unfortunately, fewer than 30% of people who currently these are diagnosed with asthma. And another unfortunate thing is the daily use of inhaled corticosteroid was less than 10%. Now, if somebody thought that asthma doesn't kill, that's not true. There are as many as 250,000 deaths annually, and 80% of deaths are in a developing country. And unfortunately, 2 of the 3 such deaths are preventable. So, what is the goal? The goal of asthma is to reduce impairment and freedom from frequent symptoms. And another goal is prevention of recurrent exacerbation, also prevention of loss of function. And I'll be actually focusing more on the second part, because as far as the ABPA is concerned, it is a disease which can lead to severe crippling. And what we desire when we are managing asthma, we want people like Parupuli Kashyap. He is an asthmatic, who is a gold medalist in badminton. Christie, who is an ice skater. Bandit like Beckham, the footballer. Alan Border, and the Calcutta boy, who went to the peak several times despite being asthmatics. Can we achieve that? If you want to achieve that, you need to make a correct diagnosis and also manage this correctly. Over the period, a lot of phenotyping has occurred, the specific treatments are there, and there have been several developments starting from inhaled corticosteroids in 1972 as came, and then we progressed, and Gina came in 1990, and then came leukotriene antagonist and LABA-ISCS combination. Then came omalizumab and anti-IL-5 biologicals, which I'll be touching upon. So, the topic of the day is ABPA, that is allergic pulmonary bronchopulmonary aspergillosis. I'll be reciting it as ABPA. Is it an uncommon disease, or we are missing the diagnosis? That is the question that I'm going to put across and also try to answer. So I start with the case. This is a 24 years old girl. She's an advocate. She came in the year 2020. She presented an asthma, with a history of asthma and also family history of asthma. She presented to a center with cough, with hemoptysis, with breathlessness, and she was diagnosed tuberculosis. And if you see she underwent a CT scan at that time. And if you see this CT, the picture, you can see bronchial wall thickening. This is the bronchial wall thickening. This looks like bronchiectasis, nowhere near tuberculosis, but and there are some nodules that you can see here. Now, since she had history of asthma, but she had hemoptysis, she was put on anti-tubercular treatment, which she received for 1 year. 2022, again, she received ATT for a period of 1 month without any response. And then received antibiotics for 1 month with partial response. She presented to us in the September of 2023 with a fever for 1 week. She had cough with expectoration for 3 months. She had shortness of breath for 1 month and wheezing for 1 month. And on examination, she was comfortably sitting. And there were some wheezes which could be heard. And this was a CT scan. See what has happened to this young girl, 24 years. In 3 years' time, there is a complete destruction of both the lungs with bronchiectasis. And in fact, the cavities have been formed. So we investigated, we did a PFT. PFT showed a restrictive ventilated defect, as would be expected, with the vital capacity of 55%. But there was a reversibility of FEV1, although the ratio was not reduced. So we further investigated the blood investigation. The hemoglobin was 11.4, TLC was high, the eosinophils were 1510, and the total IG was more than 5,000. Now, the laboratory were not reporting more than this, and when we did Aspergillus specific IG, it was 69.2 units per liter, with again the normal of 0.1 to 0.35. So the diagnosis was allergic bronchopulmonary aspergillosis. Clearly, that was a misdiagnosis. So I will be building upon this particular case to put across my point. You cannot talk about ABPA in anywhere in the world without talking about Professor Ritesh Agarwal, who is a professor at pulmonary medicine at the PGI Chandigarh. He has done such an amazing work, which is quoted all over the world. So how common is ABPA? 0.7 to 3.5% patients who are referred to secondary care with asthma do have ABPA. If you talk about tertiary care center like PGI or AIMS or other bigger hospital, 2 to 32% of patients with asthma with the average prevalence of 13% would have ABPA. Allergic sensitization to Aspergillus fumigatus is more than 6%. And global burden is 4.8 million, and ABPA complicates 2.5% of asthmatics. In India, there are estimated 1.4 million, that is 14 lakh cases of ABPA out of 28 million. So are we missing it if it is so common? And this is the paper I was talking about in clinics in chest medicine by Dr. Ritesh Agarwal. How does ABPA occur? The studies have shown that an average human being inhales 100 conidia of Aspergillus every day. And this ABPA results from exaggerated Th2 type immune response to Aspergillus antigen. And susceptible individual mount an exaggerated response with the production of IgE antibodies against Aspergillus. And this becomes a diagnostic criteria. And this immune cascade causes chronic airway inflammation, hyperresponsiveness, eosinophil infiltration, and airway remodeling. This is the patient. This is the lung of a ABPA patient. You can see that dilatation of bronchi with the mucus, and you can sometime rarely you may find you can see the Aspergillus here, charcoal laden, and this is the histology of the ABPA. How does it present? It present mostly in the third decade, although it is said, but we have seen cases at the 60 years of age, presents as asthma with a thick brown sputum, which you see only occasionally. Quite often it is unrecognized for years, as you saw in the case. And systemic effects. Some patients may experience weight loss, fever, and fatigue. In the late stages, these patients may have pulmonary hypertension, cor pulmonale, and some will present with hemoptysis also. Now, this is important. When you investigate them, usually the eosinophil counts are more than 500. The raised Ig is more than 500 with a specificity of 70%. The raised aspergillus specific Ig, this is the most important sensitive parameter, and then I'll come to it later, is more than 0.35 units per liter. It has a sensitivity of 99 to 100%. Because of this, if you have a patient with asthma and if you want to rule out ABPA or sensitization with fungus, just do a raised aspergillus specific Ig. If it is negative, then you can safely rule out and raise aspergillus specific IgG of more than 27 per liter. Now, lung function test will show a variable airflow obstruction with bronchial hyperresponsiveness, and it may be valuable for assessing the severity. In later stages, there is a fixed airway obstruction. Now, there are some new tests which have come. That is recombinant aspergillus antigen. There are currently commercially available recombinant antigen, Aspergillus fumigus antigen, RSP F1, F2, F3, F4. They are thought to be highly specific. Besides this, there are other tests also which indicate eosinophilic inflammation. Radiology is very important. Now, if you see the radiology of ABPA, there is central bronchiectasis, which is actually hallmark, but I would come to it that not every patient has the classical central bronchiectasis. And this is a dilatation and thickening of the bronchial wall. I'll show you some, like this is the classical picture of central bronchiectasis that you see. But it's not confined to only center. You can see the dilatation in the lateral part of the lung also, and you can see a lot of nodules there, and these are the bronchiectasis which is seen in the distal part. Now, there is a mucoid infection and accumulation of thick tenacious mucus within the dilated bronchi is seen in ABPA. They obstruct the lumen, lead to distal atelectasis, and the classical finger and glove opacity and also high attenuation mucus. Now, this is the classical thing that the bronchus is filled with the mucus. And now, this is another patient we got which we thought was a collapse of the lung. Possibly he had a lung cancer, and it came out to be ABP. Now there could be other findings also. You have to have a high index of suspicion and infiltrates that are often associated area. As you can see, these are nodules. There are bronchial wall thickening. These are nodules, and this is classical finger and glove appearance. If you see this on a CT scan, there is no differential diagnosis other than ABPA. Later stages, there will be fibrosis and scarring in chronic cases, leading to severe respiratory disability and lung damage. Now, this is what you see. There's no proximal bronchiectasis. There's some pleural component also, and a lot of centrilobular and random nodules you can see. And this is all because of bronchial infection in the smaller airways. Now, this is another case we got, 45 years old male from Bihar who presented with respiratory symptoms. And we thought we are dealing with the lung cancer. And when we did the CT scan, further we saw the collapse of the right upper lobe. So we underwent a bronchoscopy. And you see, there's an infection of this segment was completely blocked with the mucus, and it was difficult to suck it out. And you can see while we are applying suction, and at the end of it was completely open, and it was diagnosed to be classical case of ABPA. And this is the classical high attenuation mucus, which is pathognomonic of ABPA. So radiology helps a lot. And this is a finger and glove appearance with bronchiectasis, proximal bronchiectasis. So the final diagnosis, now come back to the 24-year-old girl, unfortunate girl, an advocate who presented to a doctor 3 years back, and since it was not diagnosed, she has reached this stage because of the investigations. We diagnosed it allergic bronchopulmonary aspergillosis. So the diagnosis, coming to the diagnosis of ABPA, it's a combination of clinical, immunological, and thoracic imaging. The International Society of Human and Animal Mycology, headed by Dr. Ritesh Sharwal, has proposed recommendation for diagnosis of ABPA, and initial diagnoses were given by 2013. I would like to draw your attention on these diagnostic criteria. Patient with asthma, patient with aspergillus specific IgE of more than 0.35 Ku units per liter, and serum IgE of more than 500 internal units, and at least two of the following: Aspergillus fumigatus specific IgG of 27 or more, bronchiectasis on CT chest, and peripheral blood eosinophilia of more than 500 per cubic milliliter. There are 7 stages of ABPA which was given, but not all patients go through those stages. So I don't think that is important. Now coming to the management. How do you manage ABPA? Now the treatment goal is to control pulmonary inflammation, preventing exacerbation, minimizing treatment-related adverse reactions, extenuate the onset of progression of bronchitis. That is the most important. If in a patient with asthma who has ABPA, if you miss the diagnosis, there are all probabilities that this patient will go into chronic pulmonary bronchiectasis, may go into the fibrosis, may go into respiratory failure, may have hemoptysis. So, how do you treat? The sheet anchor of treatment remains oral corticosteroids. Please, we say don't use steroids in asthma, but if the patient has ABPA with bronchiectasis, you have to use corticosteroids in the dose of 0.5 milligram per kilogram body weight. Usually we give 30 milligram dose in a usual patient with 50 to 60. You give for 1 to 2 weeks and you taper with by every 5 to 10 milligram for every 2 weeks until you reach something like 5 to 10 milligram. The high dose regimen could be a 0.75 milligram per kilogram body weight, but it has not shown any benefit. Now, inhaled corticosteroids should be used as required for management asthma, but should never be used in isolation. If you have diagnosed ABPA, you must use systemic corticosteroid also. Now, corticosteroid, some patients would become corticosteroid dependent, and 50% of patients will relapse when the systemic corticosteroids are reduced, and up to 45% become steroid dependent. In that case, there is a role of antifungal strategies could be considered. And some studies have used both corticosteroids and the antifungal to be used simultaneously. My personal choice, I work from case to case. In severe cases, I do start antifungal at the same time in the hope that patient will improve faster and would require lesser doses of steroid. Among the antifungal, the most useful which has been found is itraconazole. It should be given for a period of 4 months in 200 milligrams twice a day. It reduces the steroid and also it reduces the IgE level. Voriconazole and posaconazole have also been used, but voriconazole is very expensive. So is posaconazole, and voriconazole has million interactions also. My choice remains itraconazole for this one. Now, I'm not talking about cystic fibrosis population because, and some people have also used amphotericin B in the nebulized form, but this is anecdotal and not recommended. Now, one of the in the inaugural comment, it was commented on biologicals. Now, biologicals are very important, but they have not been used systematically in a randomized trial in ABPA. But lack of evidence is not evidence to contrary. So, biological drugs for ABPA is associated with significant clinical improvement and reduction of exacerbation to the tune of 90%. Omalizumab seems to require more time to achieve improvement, and functional improvement and post-treatment FEV1 is achieved. Now, these are omalizumab, mepolizumab, benralizumab, and dupilumab. They are all used, but you could see the number of patients they have tried 133, 162, 7, and they all reduce the IgE and they all reduce the eosinophil 70%, 95%, and 90%. They all reduce the exacerbation rate 90%, 85%, 90%. Now, the question is there is no head to head trial, unfortunately, but you should consider it because omalizumab causes reduction of IgE by 45% and eosinophil count by 70% and improves the lung function. Same as mepolizumab also reduced the IgE by 67%, in eosinophils by 95%. As you know, mepolizumab and benralizumab are both used for eosinophilic asthma. Similarly, benralizumab also reduces by for eosinophils by IgE by 40% and eosinophils by 99% with concomitant improvement. Same is dupilumab. So the review of 32 studies revealed that biological treatment with omalizumab, mepolizumab, and dupilumab and benralizumab tended to favor patients with ABPA and asthma. Now, the thing is, when should you use it? That is a question. If the person is steroid dependent or frequent exacerbation despite taking steroids and antifungal and having side effects of steroids or are unable to take steroids. So therefore, for ABPA, monoclonal antibodies have a future. Another important thing I would like to emphasize that although Aspergillus specific IgE is important for diagnosis, for follow-up, it should not be done. The follow-up is done by clinically, by PFT, and also by serum IgE. And HRCT should not be repeated only if required on clinical. This is my final point that I want to make, severe asthma with fungal sensitization. Now, every patient with ABPA, actually to start with has asthma with fungal sensitization. Is there a wisdom in picking up this entity at that stage and treat it so that it does not? Now, what is severe asthma with fungal sensitization? It is a patient with asthma with raised eosinophil count, raised IgE, with raised specific IgE and IgG with a normal scan. Then you call it. So how common it is that the prevalence of Aspergillus sensitization in bronchial asthma is ranging from 15 to 48%, with the pool prevalence there. So therefore, it is fairly common. But you can't be treating all these patients with systemic steroids. But it is important if there is a cutaneous hypersensitivity or specific Ig antibody in an asthmatic with raised IgE without bronchiectasis on CT scan, then you call it. Now, the use of 500 microgram per day of fluticasone. So, how do you treat? Fungal sensitization does not require systemic steroids. It should be treated only with inhaled steroid and bronchodilators. So, if the total IgE is less than 1000 units, positive skin test or reactivity to Aspergillus fumigator, elevated serum IgE to Aspergillus fumigator, absence of serum proteins, elevated specific IgG to fumigators, and no radiological evidence of bronchiectasis. So treatment of these patients should be with the usual LABA and ICS, but these patients must be followed every 2 to 5 years for development of ABPA. This is what the recommendation says. So the early diagnosis is important. So ABPA is of major clinical importance because bronchiectasis is prevented if disorder is diagnosed early. Notably, many patients with asthma will develop aspergillus, and no person like this unfortunate girl should progress from uh, simple ABPA to complicated ABPA where the lung is destroyed. So this is my last message. How do you suspect and how do you diagnose patient with ABPA? If you have a patient with bronchial asthma, severe asthma, you do his aspergillus specific IgE. If it's more than 0.35, as I said, it is up to 99% sensitive. So there is a probability that this patient has ABPA. Then you do a total IgE. If it is more than 500 units per ml, then you do peripheral blood eosinophil. If less than more than 500 per cubic milliliter, and if the aspergillus specific IgG is more than 27 milligram per liter, then you do a CT scan. And now when you do a CT scan, if the CT scan shows a high attenuation mucus, it is called ABPA hem. If it shows proximal or bronchiectasis, it is called ABPA bronchiectasis. If the CT scan is normal, it is called severe asthma ABPA sensitization. So this is how you divide, and your treatment would vary accordingly. So, ladies and gentlemen, my take-home message is that ABPA is largely unrecognized, potentially treatable disease. All patients with asthma should be tested with IgE or Aspergillus IgE. In such cases, HRCT should be done for evaluation, as I have already said. Judicious use of steroid is warranted to prevent the damage to the lung and for symptomatic improvement. Antifungals have a place in management, can be started at the outset from case to case basis. There's a role of biologicals which needs to be explored, and inhaled medication should be used as in asthma. Finally, no patient should reach the stage of pulmonary fibrosis, hypoxemia, and cor pulmonale. Thank you for your kind attention, and I'll be ready to take any questions. Thank you very much.
Thank you, sir, for your excellent review. Now I request Dr. Ravi Mehta to take over for further proceedings.
Yes, thank you very much, Dr. Biradar, for calling us. And thank you, Dr. Kellani, for a very detailed and educative talk on upcoming entity largely brought on the global scene by a lot of Indian efforts, as you pointed out. Do we have any questions on ABPA on the talk?
Yeah, right now there are no questions on the chat.
Yeah, I'm so sorry. Chat box says one question, Dr. Khilnani, how long the treatment with biologics is to be continued? One assumes the question is for ABPA.
Yeah, I've already said by the limited knowledge that we have on biologicals in ABPA, it should be used only as in patients who poorly respond to corticosteroids and antifungal, and also who cannot tolerate steroids because of uncontrolled diabetes or whatever, which will be too many. But there are no head-to-head trials, number one. As in patients with asthma, severe asthma, where we use biological, no duration is defined actually. So, and there are no long-term or head-to-head trials. So I should think if I was to give biologicals for ABPA, I would give it for at least 1 year. But this is my opinion, not from any study or knowledge. And if you can add to Dr. Mehta, if you want to add, you're welcome to comment on this.
Yeah, no, it's a good question, and you're often wondering whether the biologics are controlling the ABP or the asthma. So that's another big question which comes up when you treat this entity with biologics. The final word is clearly not there. The second question one would have is how long do you treat with antifungals for that matter?
Yeah, see, the thing is that firstly, that majority of the guidelines do not propose that you give antifungal. That is one. Similarly, Dr. Ritesh's guideline also, who has done the maximum work, as I said. But the thinking is that which I actually propose that if a person is a severe ABPA and at the risk of damage to his lungs, the proposition is that it reduces the fungal load. The current guidelines say that you give it for a period of 4 months. Some people prefer voriconazole being more potent for aspergillus. I still use itraconazole being affordable and better tolerated. In fact, in patients with who have not asthma, but if the ABPA is with the cystic fibrosis, then they seem to prefer posaconazole. But there are no head-to-head trials to my mind which can. But if I could give my opinion, in severe cases, I do give itraconazole because one thing is certain: when you give antifungal, you are able to reduce dose of corticosteroids, which is actually evidence-based.
Okay, that sounds good. I think we're ready to start the panel discussion. Any questions from the faculty or anybody else on Dr. Kelnani's talk? Dr. Satish, Dr. Nagarjun?
Ravi, can I come in?
Mehta sir, Satish sir, good evening. Can you hear me?
Hi,
Very
hi.
well, Nagarjun. Nagarjun is
Sir?
coming to us bravely in the midst of a thunderstorm from Hyderabad.
So, sir, my video is not good, so I'll just try to be there on the audio as long as I can, sir.
Oh, that's wonderful. Thank you. We appreciate the effort and your voice speaks for itself.
So,
Satish, anything from your side?
No, nothing. I just want to say I have a patient now, Professor Kilnani, where I've used as recommended steroids and then antifungal, which he was not able to tolerate itraconazole. Then posaconazole was used. And then ultimately, a few years back, omalizumab, no response. Then mepolizumab, again, all tried properly and he could afford, fortunately. Now he is on benralizumab. He's okay. His eosinophil count is 0. Still gets some exacerbation, never hospitalized on a maintenance dose of 5 milligram. He also has a prostatic cancer. He is about 80 years old now. And as you rightly said, we must prevent patients getting into fibrotic stage, carpulmonale, and respiratory failure. We must detect early. I think the message was very clear in your talk. So detect early, have a high index of suspicion, and preventing these kind of complications requiring the modern modalities of treatment. Just to highlight how difficult it is sometimes to treat these patients. Thank you.
So, if I could come here, Dr. Satish, thank you very much for your comments. We all have difficult patients. So, since aspergillus specific IgE is not so widely available and it is a little expensive, even in city of Delhi, it takes 3 days for the report to come.
Yeah.
I start with serum IgE, which is widely available. If it is more than 500 in a patient with severe kind of asthma, then I move ahead and do specific IgE and then CT scan.
Yeah. True.
Dr. Kelly, sometimes you're faced with these complex patients where you basically have this bronchiectasis and you have ABP and you wind up treating with steroids and they get super infected with these interestingly crazy bugs, which you have written about also in your resistance guidelines. And then you're playing the dance between treating an MDR Klebsiella and trying to control the ABPA. And then the asthma flares up because of either one of them or both. And that becomes quite a challenge. And I don't know in these patients, antifungals, of course, how much of an impact they actually have on the course of the disease. When you have the infection driving the asthma and ABPA control becomes a moot point. Any thoughts on these? Because 2-3 patients have come by which have been a real enigma in this situation.
So, Ravindra, these guidelines are not to be followed to the word. That's of course we know that. You have to use guideline in the context of the patient and the local condition. So I don't say that if the moment you diagnose ABPA, you start giving him steroids for long term. I actually I give variable dosages of steroids and taper also invariably. I don't follow the exact regimen given by the guideline. And of course, steroids have million adverse effects. So the bottom line is two. It is not that you want to impress the patient that you have, uh, cured of the symptoms and you may jump with joy with steroids. My message, why I took up this subject when I was given a choice to talk on asthma on some side, some part of asthma, because managing these patients and having little high index of suspicion, that I strongly feel that judicious use of antifungal as well as steroid can prevent the lung damage and the chronic bronchiectasis to large extent. If that message is there, and I totally agree, if you have bronchiectasis and you load them, and there are some patients when the stage comes, when the bronchiectasis is already set in, then at that time there may not be wisdom in loading them with systemic steroids because the airway obstruction has become fixed. So you have to use, we have to use our knowledge and understanding in the interest of the patient. And first, as the French, primum nocere, as we call it, first cause no harm. So I really appreciate Ravindra your comments on that. That's a word of caution.
Yeah. So more lovely antithetical controversies which come up in treatment. On one side, we have the asthma people talking of the fact that even 1 or 2 asthma steroid courses, and please note this line, 1 to 2 asthma steroid courses for exacerbation of asthma are associated with higher cardiovascular mortality, osteoporosis, and so many other things. Proper paper, 2018-2019. On the other side, we're pounding steroids in a condition which basically is much longer and which will inevitably control the asthma, but will lead to all these potential cardiovascular, osteoporosis, diabetes, mood changes, and so on. How do we reconcile these two aims?
Oh, okay. So let me clarify that point. I have focused on severe asthma with fungal sensitization, and I emphasize they must not be treated with systemic steroids or antifungal drugs. The recommendation is that every 2 to 5 years, you should review them for development of bronchiectasis, and that you can do only with the CT scan. So I totally respect your sentiment, Ravindra, that you must not be over enthusiastic just because the specific IgE is positive to aspergillus or the IgE is very high. We see IgE of 5,000, 10,000. We all see that. And if the specific IgE is high, if the CT scan doesn't show bronchiectasis, please do not load them with steroids or antifungal. You just have to watch them for development of bronchiectasis. That is what the recommendation is. On the other hand, if the patient is severely symptomatic and has started developing bronchiectasis, what is called as ABPA bronchiectasis, that is the time I think it is okay to take risk of giving them small dosages of steroids in a tapering dosages, not only for control of symptoms, but also for further damage. That's why I say that I may be going against the guideline, but I almost always in the confirmed cases of ABPA bronchiectasis give itraconazole or voriconazole.
And how do we explain the fact that antifungals don't work very well for aspergilloma, but they'll work for ABPA?
So they don't work for ABPA in that sense, because as I said in my presentation, that as per the studies done, an average human being inhales around 100 conidia of aspergillus, somewhat made. So the aspergillus would, we believe that antifungals will reduce the load of aspergillus, but the day you stop antifungals, again you are back to square one. From next day he starts inhaling, aspergillus, and so that's why the benefit is not confirmed. But the Ritesh study, he's a stalwart in this. Study has shown that when you use antifungals, marginally the steroid dose is reduced. That is also a gain to and I find itraconazole very well tolerated drug. And I have problem with voriconazole, so I don't give for this.
Okay. Well, thank you so much. We'll start the panel discussion. Dr. Biradar, maybe proceed.
Ravi,
yeah,
before
Dr.
you
Murali
go
Mohan,
ahead, can
Murali
I
Mohan's
ask one
comment.
question?
Yes, Murali, please add to it. I love to see a library in the back. Huh?
Professor Kilnani, when you have a very high IgE, but your aspergillus specific IgE is negative, would you be hunting for other fungi?
Sorry?
Other forms of aspergillus, other than aspergillus, would you search for other mycoses?
So that
And
is
there
why,
a separate treatment for that?
that is why some people are very fond of saying it is not aspergillus, it is not ABPA, it is the mycosis, the allergic bronchopulmonary mycosis. I do not have the answer for that, but if there is a, you know, the HRCT is such a fine investigation, such a simple investigation. If with the raised IgE, now I'm saying something from my thinking, not from any evidence. If there is a bronchiectasis or bronchial wall thickening, I will have a very high suspicion of allergic bronchopulmonary mycosis if the specific IgE doesn't come positive. But how would I manage it? That's very difficult to say, but possibly I would give them small doses of steroid. But having said that, I have not diagnosed any other mycoses in such cases. Would I answer, Ravindra? I didn't answer your question that you said why this antifungal don't work in aspergilloma. I know you are a astute intervention pulmonologist, but it's not true. In patient with hemoptysis associated with aspergilloma, antifungals have shown to be of beneficial. Of course, they don't. The aspergilloma will not disappear. In names, Vijay Hada actually instilled ketoconazole bronchoscopically and demonstrated control of hemoptysis, not the disappearance. Some reduction in aspergilloma was documented.
One more question, Dr. Kilnani. Do you think that basically ABPA with bronchiectasis is a typical Indian disease of neglect? Not seen much in the West, such horrible things. Caught much earlier in other places just because we don't catch things early that we're talking about this entity so commonly?
I think so. I mean, you have hit the nail actually. And what we am saying, after leaving AIMS, and AIMS I was busy in critical care. You know, my all work, research work, guidelines were. But as I came into practice, I saw so many cases. I can't even tell you because my unit has a little bias towards ABPA for last 4-5 years. So one thing is certain that it is missed very badly, and you and me see a lot of advanced cases. So therefore, this lecture is to make people understand that suspect it, or unless you suspect it, you will diagnose it. If you remember, since I'm much older than you, 40 years back when I started doing, entered pulmonary medicine, ABPA was diagnosed only when there was fleeting shadows on X-ray. Otherwise, ABPA was not considered at all. And the only test available was skin prick test, which was available only in BP Chest Institute. So even in AIMS, we were not diagnosing it. But now, when the specific IgE is so freely available, with maybe a bit of the cost, and it's a 99% sensitive test, I think we should not miss it. That is the message.
So Dr. Abhay Devra wants to ask you that should antifungal like itraconazole take precedence over steroids in SAFs? And that's
Sorry?
one question. And Dr. Abhay Devra on the chat is asking us, should antifungal like itraconazole take precedence over steroids in SAFs, severe asthma with fungal sensitization?
No,
And
no,
the
not
second
at all.
question is whether steroids for an indefinite period exacerbate the fungal infection, which is a conventional adage basically.
So I know the answer for the question number one. And answer is big no. With fungal sensitization is so common in 6 to 10% or 20% of asthmatics. If you load them with steroid, you are causing big disservice. As I'm third time I'm saying, the recommendation of the experts is that every 2 to 5 years you screen them for development of bronchiectasis. And second question was, sorry.
Will steroids for indefinite period exacerbate the fungus? Conventional teaching is don't give steroids in
Absolutely.
fungus, right? So
Absolutely. But you don't give steroids for indefinite. Actually, if I may be having patients for last 4 or 5 years who are for ABPA, ultimately we actually stop their steroids. And quickly you come to 10 milligram or 5 milligram of prednisolone, and there should be all efforts to follow them up with lung functions, with IgE, so that you aspire to stop steroids completely and manage them with inhaled steroid following their damage. And I don't think anybody has experience of managing ABPA for a particular patient for 20 years or 30 years as to what happened. I'm not aware of that.
right. Okay, so we'll get down to our discussion beyond this. It's been a interesting litany of questions on a very provocative topic. So let's come down to the reason we are all here. World Asthma Day 2024. Interesting themes are coined by in the context of this particular day. This year's theme is by and large asthma education empowers. Nagarjun, why do you think this is there? What is the importance of asthma education? In fact, it sounds so cliche because it's part of every standard disease to educate people, right? So why so much attention and give it a whole importance on a once in a year event? Is Nagarjun there, or has he been besotted by the storm?
I think he has lost his connectivity.
Yeah, Satish, can you take this?
I'll be happy to take this. Okay, being in practice for so long, I think we have all been emphasizing on education and educating patients about not only management of asthma, but also awareness about asthma. As Professor Kildani mentioned, that we have 32 34 million people suffering from asthma in India, and about, I think, 1.9598 patients dying of asthma. India, number one in the world in terms of asthma deaths. So he mentioned about reducing mortality and morbidity, which is very true. That's why, like chronic diseases, hypertension, diabetes, and other diseases, you manage yourself by, for example, in diabetes, by taking insulin more, less, and things like that. Here also in asthma, you can still manage by knowing about the inhalers, knowing about when to increase the inhaler, and reducing by educating them about it. And also, I think emphasizing on timely seeking medical advice. And we don't have to see patients in our ICU if we manage our outpatients asthma properly. And there is no way we can, still we can get some patients who have a brittle asthma in our hospital. But timely seeking medical advice and also educating them on the onset of an acute exacerbation or symptoms which are uncontrolled, to increase the inhalers, and also if necessary, to start a steroid on their own. So basically empowering them about educating about asthma management, and also seeking medical advice on a timely basis will help patients in managing their asthma better and preventing. One of the goals of treating asthma is to prevent hospitalization, and apart from good quality of life and maintaining a good lung function. I think that's all covered in this theme, Ravi. Little elaborate.
Okay.
But
Yeah, so I'll make it more interesting, and maybe I'll lean on Murli also to substitute for Nagarjun. Murli, sorry for that, but I know you're an impromptu person. Murli, modern times 2024 is social media, the industry inundating us with tons of resources which are randomly coming today. Also, go on to this website, that website, and thirdly, AI. Is it that there is a specific meaning to education in 2024? Beyond what Dr. Satish said, in view of all these contexts, which can help the busy physician to actually do a better job of this education aspect?
Yeah, as resources increase, I think definitely the opportunities to use these resources improves, and we can reach a larger number of people through multiple media, social media and others. The problem is that the opportunity for misinformation also increases several fold. And there's this old statement that Alai has traveled around the world before truth gets its pants on is very true, even in asthma. So we see a lot of misinformation, and our patients come in with that misinformation. So, I think the theme is very well chosen, and we need to use all resources possible, AI included, to transmit the right information and educate. And I started off, Ravi, before you joined us, by saying we need to educate patients, we need to educate ourselves, and of course, we need to educate the public at large. And one group we have always failed to educate is the people who are in charge of programs, the government, the healthcare authorities. We need to emphasize how important it is to, pick up problems like Professor Kilnani said, improve availability for the common man to make a diagnosis of ABP. And as he said, the investigations needed are so expensive that the ordinary person just cannot afford the detailed investigations that are often needed. But the screening investigations at least should be available.
Right, fascinating. So then it comes down to GINA 2024. Now, what is new in GINA 2024? You can't have a discussion on asthma without GINA. Dr. Khilnani, anything which is there, because GINA tends to sometimes you feel put out a 230-page guideline, and fortunately they've got these 2 pages of what is new. Otherwise, you're busy sifting through what is what you have to change in practice. So your education becomes alarmingly, prohibitively difficult as against the theme which has been espoused this year.
Yeah, I mean, as I said, my primary interest has been in intensive care and web and so on and so forth. But I have been following these guidelines as they come as a part of my job. So the GINA first thing I said, which is actually I'll take only a minute, only for mild asthma. The only change that I find, I've screened the guidelines some time back, that we used to talk about salbutamol or short-acting beta-2 agonist inhaler for SOS use. And then there were guidelines saying if it requires more than twice in a week, blah, 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 then you consider using corticosteroid. But then the Sigma trials and another trials, and good thing about GINA is that it gives an evidence, whatever it says. So it said that even for mild step 1 and 1 asthma, that you should not use short-acting beta-2 agonist. You should use short-acting beta-2 agonist along with inhaled corticosteroids, and it reduces the exacerbations and it reduces the long-term outcome. This was the primary thing which came to my mind, besides other thing, downsizing the LAMA in management of asthma or dumping the theophylline. I think I would like my other panelists to contribute. I've spoken too much during last 1 hour.
Satish, anything you want to add?
Ravi, as Professor Kilnani initially also mentioned in his talk on ABPA, that guidelines are always there to guide us and we can adapt them to our local needs. And they give you guidelines, say, for example, there is no role for oral medication, theophylline, no role, the salbutamol, no role, syrups, no role, and use judiciously leukotriene receptor antagonists, and then the biologicals and blah, blah, blah. I think basically GINA gives us every year some update on scientific evidence, and there are RCT evidence. They all sit together, I think about nearly 50 people, including a respiratory nurse, respiratory physicians, general practitioners. Everyone is there to formulate this guideline. So it's quite useful, Ravi. And when there is something new, for example, as Professor Kilnani was mentioning, no role for SABA. I like that. Simply because, there was confusion between this intermittent asthma and mild persistent asthma, track 1 and track 2 asthma. So very clearly mentioning about to everyone that there is no role for monotherapy with SABA. So something like that, and some new what is new in asthma, if you see, as you said, there are 262 pages of this, and something about using spirometry, yes, if not peak flow meter, and also reversibility, cough variant asthma, children with asthma, obesity asthma, pregnancy with asthma. So there are some new guidelines and what to use, what not to use also is there. So it helps every year for us to practice evidence-based medicine depending on the GINA guidelines.
The interesting part, I think I've known sometime from my comments, which may be a little too frank, is that the companies who take us to their websites where they have education going on, who get foreign speakers, are the same companies making salbutamol, making aminophylline, making tab-as-selin, which is still being talked, marketed, sold, has a significant, revenue stream,
Yeah.
and they're all over the country. How do you reconcile that paradox? Murli, this is something, and we speak for these companies also often, and they may be sponsoring some of our programs, if not the one right now. Unmute, Murli.
Is
Can't
it
hear you,
there?
Murli. Murli is there, but somehow we can't hear his voice.
No, can you hear me now?
Yeah, much better now.
Okay. So one of the things I've always been against is this salbutamol, beclomethasone or salbutamol budesonide combination. But I think looking at the latest guidelines, when you want to use an inhaler for relief combined with the so-called MART therapy, then, it actually makes sense because your limit of formoterol, and even I think the current guidelines say that formoterol is 72 micrograms a day. So you can't take more than 8 puffs of this combination whether you're using track 1 or track 2. In that case, using salbutamol along with an inhaled corticosteroid has suddenly started to make more sense. I've fought it for 20 years, and now suddenly I'm saying, no, maybe it's not a bad idea. Salbutamol alone certainly should not be used, any form of beta agonist, short-acting beta agonist alone. But they have an argument, I suspect, that it may be useful in patients with COPD, where you want to use something without giving too much of steroid. So I think the answer is not that, we can ban it completely. I don't think we are going to succeed. But I think what we need is to educate our own fellow professionals and the patients that you do not use a SABA alone, and enlighten them about the dangers of using SABA alone.
Right. So I think you've talked about a question which I wanted to bring up also. So mild to moderate asthma, current perspectives, what is new so that the average physician can look at the updates on that? Anything, Dr. Khilnani?
Not really. There's hardly any change. The old concept of, I strongly feel there's no wisdom in using high dose inhaled corticosteroid. This is my practical experience also, giving higher dose of corticosteroid never brings a better control of asthma. So using a moderate or low dose steroids, inhaled steroids, is the key. And this is not new in this guideline. It has been there in the previous guideline also. And only thing is that it has been re-emphasized, and I'm a strong proponent of this.
Right. So Satish, come down to the big the tiger in the jungle, severe asthma. Any thoughts on severe asthma, right from workup all the way to treatment in 2 to 3 minutes? I'm going to put a cap on your time, unfortunately. And what is new in that? Again, like you said, 4 decades of practicing asthma from your side across 2 continents.
Severe asthma comprises about 5 to 10% of our asthma population, but consumes a lot of costs, direct and indirect costs. So this must be prevented. If not, the treatment, of course, the goals of treating here is again preventing exacerbation, hospitalization, and ICU admission, and so on and so forth. So here, what Dina is saying is, you use higher doses of moderately high, and I fully agree with Professor Khilnani regarding use of higher dose, because when you start initially, many of our patients do not come back because they feel good, they feel nice, their asthma is under control. They're on 1,000 micrograms of fluticasone forever. So because they're happy about it. Of course, many of them stop in between. Those things also happen. So coming back to your question, Ravi, I think there's a role here about various other add-on medication. For example, add on with LAMA, leukotriene receptor antagonists. If they are useful, then you continue. Otherwise, don't continue them. And if they are not useful, then evaluate them mainly in respect to compliance and adherence, whether they're taking these medications regularly. And we are missing anything in these patients, like, for example, the talk of today, like ABPR sensitized asthma, fungal sensitization, and bronchiectasis, and so on. So you rule out all that, and you're left with this 5 to 10% patient which have severe asthma, difficult to control asthma, in spite of maximum inhaled corticosteroids and others. Then you manage them with what you have now, biologicals. And even though affordability is a big question mark in India, so these have really made some definitely groundbreaking impact on patients long term and preventing exacerbation. And there are definite guidelines in when to use these biologicals and how long to use and what to choose and those things. I think I'm sure there will be subsequent questions on this, Ravi. That's what the Gina is stating in step 5 asthma, moderate to severe doses, add-on medication, not better than biologicals.
So Murli, I think to add to Satish's point, the whole science of severe asthma is based now not only on clinical, which is important, and we thrive on that, but also what's called objective inflammometry, that you do now tests for that. So does that make this a more complex disease, that the moment we talk of severe asthma, resource limited settings is not going to do justice? B, you need a center which has inflammometry. And 3, Satish used the word biologics, which we'll ask more questions on, will require certainly a deeper thinking and analysis before we try and deploy these tools.
Yes, I mean, I completely agree. I agree with everything Satish and you have said. I think the point again that you had spoken to Professor Kilnani earlier about, Dr. I think Abhay Diora's question about the use of oral steroids, will it make the underlying infection worse? Is in every case, we are doing a risk-benefit analysis. Now, if the risk of having poorly controlled asthma is very high, and you need higher doses of inhaled steroids to control it, you may have to go to slightly higher doses. It depends on what your goal is. Your goal is set, say, I have to control this asthma. It's affecting this person very badly. He's not able to go to work. He's not able to earn. Makes sense to use higher doses of steroids with an occasional punch of oral corticosteroids if necessary. Will it get better if I use a triple combination, including a LAMA? I would probably try that first. But I think the goal is to get it under control. If the patient can afford a biological, I would probably move towards, doing the inflammometry, as you said, for assessing, will he benefit from biological? Will he not benefit from a biological? Should I move to something like azithromycin or a bronchial thermoplasty, which I know you're doing? So it all depends on the individual patient. The guidelines are guidelines to guide us, and we take their guidance and move to managing the individual patient, causing least harm and maximum benefit to him, keeping the economic framework in mind. So I think that's how I would look at this problem of severe asthma. But I think Satish very rightly started with saying 5% or 10% of difficult to control asthma only is severe asthma. And I think it goes back to the basics. Are you giving them the right inhaler? Are they taking it right? Are the doses right? Is the device right? Those are the things. And we find that 9 out of 10 patients will not any longer be difficult to control. And I think that's the message I would like to give physicians on this group, rather than talk too much about biologicals.
So yeah, so a nice message coming out there. Again, the whole thing is now that for some of us who may not be so on board with inflammometry, it means you measure the eosinophil count and their numbers. The cutoffs are important. You get into the FeNO, fractional excretion of nitric oxide, a test which has suddenly blossomed in many parts of the country and is available. Pulmonologists are getting it also. And you put all that together to figure out that where is the patient's lung function, patient's symptomatology, and patient's exacerbations. And that has become a whole science. Just to make it more explicit, in the last 5 to 7 years, this whole science of trying to figure out asthma has focused on control and exacerbations, the two things which decide their ultimate lung function, their quality of life, their outcome, and so many other endpoints which have become important in studies. So it's taken a different connotation, and these drugs, biologics, much used in the Western world and sparingly used in the Indian context, have come to center stage because of that. Dr. Khilnani, quickly this
Ravi, can I
sorry, yes,
just add
Murli.
one little bit? You know, the interesting
Yes,
thing you're
Murli.
talking about biologicals and so on is for the first time, at least to my knowledge, Gina has introduced the term remission of asthma. You know, so we've never spoken about remission of asthma before, and it suddenly made an appearance. So I'd like to ask all our panelists about that. You know, what is your opinion of remission of asthma?
So who's biting the bullet? Otherwise, it's left with me.
I'll start, Ravi.
Okay.
I think we have, we have spoken. I think well-controlled asthma is like a remission in asthma. They're not talking about taking away the medicine, but if you see the websites and especially from the pharma companies, they're talking about biologicals, which have really, caused a long remission. And we have also had patients who were well-controlled asthma for years and years, and they're taking some mild doses of inhaled corticosteroids, doing everything that can do non-pharmacologically, and they're fine. So it's not new, but the terminology is new, because whenever we say about asthma, we say it's incurable. It's only controllable. And these terms, can be used in different ways, or remission, and patients have cured temporarily, and so on and so forth. So I don't see much, in that. I'm sure Murli will agree with that. There's a mention about this in the Gina. What is new in Gina?
Well, one is reminded of the fact that, for example, when you talked of pneumonia, and, the pneumonia part was de-escalation of antibiotics. So de-escalation and remission are common concepts which cut across lines. To use a mythological character, and please forgive me for that, it's like the Abhimanyu thing. And Abhimanyu, how do you exit from a therapy? You're giving steroids, you're giving biologics, you're giving inhaled therapy. How do you exit? And the word remission basically tells you of a state of great control of asthma, which allows you to even answer the question which all patients want: when can I reduce or stop my therapy? Again, Murli, in quantitative terms, I think it's 6 months now. They say 6 months, no symptoms. Arbitrarily decided. Nobody knows whether it's 6 months or 9 months or 12 months, but arbitrarily decided is 6 months.
Which I think is setting the bar too low, actually.
Yes, maybe. Okay, so I think we have covered quite a bit. We have 1 minute left to go. So I can probably just summarize stuff rather than go incessantly on a subspecialist litany of a complex entity. So basically, we've started off with a lovely talk with Dr. Khilnani and gone into various aspects of asthma, including the education part. And I found it really fascinating, because I think that now is the time when WhatsApp tools, AI tools, social media tools are going to be used to educate like never before. And then we've had an interesting, lively and discussion by experts, and I thank them for their involvement and excellent experience-based answers. There's around 150 to 200 years of experience in these 5 pictures over here. So with that, I hand over back to Dr. Sangram Biradar, and thank him again for giving me this opportunity.
Yeah, thank you, Dr. Ravi. One thing I want to, from your side, can you just convey the last thing about the recent advances in bronchial asthma, what you are doing, like thermoplasty and all, for few, because Abhay Devra is from Jodhpur, he is very keen on all those things.
Yes, we like Abhay's enthusiasm. So basically, as we try to point out, the recent advances are, first of all, look at the asthma part of it very differently from what is their problems from the point of view of patient perspectives, which is symptoms. Then you look at the point of view of controlling inflammation. And the third is exacerbations. So if I can talk of one entity which has taken center stage in the last decade, it's exacerbation. And then the focus shifted to severe asthma, where they added, the high dose ICS was talked about, and those things you have to either have on a piece of paper in front of you or just memorize them. We do it because we can know it because we do it regularly. And the addition of the LAMA came. And the third thing, which I did not harp on a lot, I was planning to, but time is limited, is SITT, single inhaler triple therapy, which was again talked about in the Indian concept. It's like mythology. When we had 2-3 of these in India, one is compelled to use names like Premium and Triohale.
But now the science has been validated by NEGM and Lancet, where one inhaler can have all three components acting on three pathophysiologic mechanisms. The great part is you put all your guns in one cartridge. The negative part is, of course, a lot of discussion on how each one of them is working and how you can titrate these two. And asthmatics inflammation. Can cookie cutter models actually serve a customized model? So this is a controversy which is still raging. And then comes the fact that after years, a procedure entered asthma, which is thermoplasty, which by and large takes the hypertrophied smooth muscle, which is contracting and causing problems, and uses radiofrequency ablation to reduce it so that they get the benefit of an open airway, reduced exacerbations, and this is long lasting with a 70% success rate up to 5 years. As I said, there's a little tragic news also. 2024 end, the company who supports the catheter is not going to do it anymore. So for practical purposes, if you want to get thermoplasty done for now, it's by 2024 end, after which we'll be talking of the age of thermoplasty rather than the availability of thermoplasty. So this, in a very quick nutshell, without extending the conference too much, is what I think is the recent developments in the field. Of course, lovely stuff is phenotypes, endotypes, and so on. But I think that we'll have to arrange a separate webinar by itself to walk us through all those challenges. Thank you.
Yeah, thank you, sir. Before we conclude, a quick take-home message from each panelist. Dr. Satish, your take-home message.
I think it's in the theme, the asthma theme itself, that empowering our patients by educating them to manage their asthma and then to seek medical advice as early as possible when required.
Yeah, Dr. Kelani, sir, yours take-home message.
First, I just want to thank you, especially, for when I realized that Ravi is going to moderate, I was a little scared actually. Whenever he's Amitabh Bachchan of intervention pulmonology, and whenever he's at the podium, he himself rocks and makes everybody rock. He's an amazing speaker also, and does amazing things as an intervention pulmonologist. But having said that, I'm not cracking jokes, but I'm saying that whenever you make a presentation, and if there's no discussion, you feel disheartened, And on that accord, this was the best that I could think of, And it's not that I was preaching something. I learned a lot from all of you, Dr. Murli, Dr. Satish, and Dr. Vishwanath and Ravi. The discussion was what actually taught me a lot of things. A word of caution from Ravinder, about use of steroids leading to more infections, which is my passion. I don't know whether you know the antibiotics is and ICU infection is my passion. And Ravinder almost said that you are causing the infection then treating them. It's not like that. But it was amazing to meet all of you virtually and indulge into discussion on asthma. And thank you so much for.
Yeah, thank you, sir. Dr. Murli, sir, your comment.
I think two important messages. One is asthma is always controllable. We may not achieve remission, which is being talked about, but we can certainly control it better than it is being controlled now. And the route to that is education. So I think we need to have more of these sessions. And Professor Biradar, you are the master at this. So we request you to continue to do this month after month.
Thank you, sir. Lastly, Dr. Ravi.
Yeah, so I think a little to add after such lovely discussion. The bottom line is if you have 5 to 10% of severe asthma, it means that the physician can manage 90% of asthma. It comes down to that. The 5 to 10% is getting more complex. And as the literature unfolds and the sea of knowledge is difficult and it engulfs all of us, that may require an appropriate collaboration with somebody. And that is the basis of asthma knowledge and centers of excellence. But by and large, the message is loud and clear. Most of it with all these tools can be managed in regular setups.
Yeah, thank you. Thank you very much. Before I request Dr. Vishwanath to propose a vote of thanks, I thank all the panelists and all the speakers. Over to you, Dr. Vishwanath, for propose a vote of thanks.
Good evening, sir. At the outset, I thank Dr. Kilnani, sir, for this fascinating, talk on ABPA covering all the aspects, when to suspect probably difficult to treat asthma, how a physician should recognize it. I think it was a very comprehensive overview In addition to it, probably some concepts like mycosis, I think that is where we have to work a little more. Thank you so much for that excellent journey. And as usual, Dr. Ravindra Mehta, sir, excellent moderation. No, thanks for all the new concepts you have got in to it. Probably if you are Amitabh Bachchan, then Dr. Satish is the Rajesh Khanna. He's always a charmer. People love to listen to him. Whenever all the conferences I've seen, quite a lot of thank you, Dr. Satish sir. And as my chairman, Dr. Murli Mohan sir, always to the point. Remission is a buzzword, whether it's diabetes or bronchial asthma, it is soothing to hear. So we all want to hear more about it, but I don't know whether it's practical or not. And I thank all the other panelists and seniors. Special thanks to Dr. Biradar sir, always pairing such excellent webinars remembering these days. Thank you once again. Thank you all.
Thank you, one and all. We'll sign off from the. Thank you, sir. Thank you,
Dr.
Kilani sir.
Ravindra.
Murali. Yeah.
Pleasure.
Night, everybody.
Thank you, Dr. Biradar.
Thank you, sir. Thank you.
Thank you all.
Bye, everyone.
Bye, sir.
Yeah.